This is page N10, and we have already now described the anatomy of the heart and how blood flows through the heart and through the rest of the body. Now we want to learn a little bit more about the heart, and then we'll be talking about blood vessels. So the first thing we've listed here on page N10 is the electrical conducting system of the heart. Now, there is a system of specialized heart muscle cells, and they're specialized to generate an electrical current. The electrical current is known as our action potentials, and they generate this electrical current and transmit this electrical current rapidly through the heart. I want to emphasize that these are specialized heart muscle cells, cardiac muscle cells. They are not nerve cells. They're not the nervous system. The main parts of this special electrical conducting system is the sinoatrial node, commonly known as the SA node for short, the atrioventricular node, or AV node for short, the common AV bundle, or bundle of His, the right and left bundle branches, the Purkinje fibers. Now, as I wrote right here, the sinoatrial node is commonly known as the pacemaker of the heart, because that's where the electrical current is generated. Now, to help us see this better, just let's look on the next page, N11, just as I wrote right here. And on page N11, we're looking at a kind of cutaway view of the heart, viewed from the front, the anterior side. And right up here, it says SA node, sinoatrial node, and I wrote that's the pacemaker. The sinoatrial node is located right where the superior vena cava connects to the right atrium. After all, we know that the two large veins, the superior and inferior vena cava, bring blood low in oxygen to the right atrium. This is the right atrium right in here. So right where the superior vena cava connects to the right atrium, that's about where this SA node is. The SA node is a collection of specialized heart muscle cells that are designed to generate an electrical current. That was pretty good. I catch it, it jumped there. So, and now this electrical current, let me remind you of something we've already learned. We've learned that heart muscle cells are electrically joined together to one another. What do we call those places where cardiac muscle cells are joined together? Gap junctions or intercalated discs. So once this electrical current is generated, it just spreads from one heart cell to the next. They're all electrically joined together. The electrical current spreads across the atria, just as my arrows indicate. So literally, it's spreading from one heart muscle cell of the atrium to the next. And then it spreads into, right here, this area called the AV node. It's written right here, AV node, the atrioventricular node. Now, where is this AV node located? In this picture, in this cutaway view, this is the left ventricle, this is the right ventricle. This, remember, right and left are opposite of ours as we look at our patient's heart from the front. This is an anterior view. And right here, this is the interventricular septum, the wall between the ventricles. The AV node is really at the very top of this interventricular septum, right where the atria connect to the ventricles. And that's why it's called AV, atrioventricular node. It's right where the atria make contact with the ventricles. The electrical current spreads through the AV node and then through a bundle of specialized heart muscle cells known as the common bundle or bundle of His. We can just call it the common bundle or common AV bundle. It's sometimes called the bundle of His after Dr. His, who first described it. Now I know it's spelled His, but the way he pronounced his own last name was His. So that's called the bundle of His, or common AV bundle. And the common bundle then bifurcates. We've used that word before. It means to divide into two. And it forms a thinner right bundle branch and a thicker left bundle branch. And these bundle branches, again, are just specialized heart muscle cells that are conducting this action potential, this electrical current, downwards. And these bundle branches subdivide into what are called Purkinje fibers. They were called that because they were first identified by Dr. Purkinje. And the electrical current spreads from the Purkinje fibers into the ventricular myocardium, the heart muscle cells of the ventricles. So this is the order in which the electrical current spreads through the heart. And of course, we know that since it's the electrical current or action potential that causes a muscle to contract, this is the order in which the heart muscle contracts. Obviously, the atria are going to contract before the ventricles contract, because the electrical current moves first through the atria before it ever reaches the ventricles. So the atria contract, and then the ventricles contract. And that's the order. Let's again summarize the order on the previous page, N10. I'm sorry, right here on N10. So it literally goes SA node, and I wrote in here atria. That's atria are not technically part of the conduction system, but it's going to spread from the SA node, atria, AV node, common AV bundle, right and left bundle branches, Purkinje fibers. And again, ventricles are not technically part of the conduction system, but then it spreads finally into the ventricles. Now we wrote at the very bottom that there are autonomic motor neurons that innervate the heart. And where the autonomic motor neurons connect to the heart is at the SA node and AV node. The purpose of the autonomic motor neurons, we wrote, is to modulate the heart rate. You'd say, what does that mean? Modulate means to speed up or slow down. In other words, the pacemaker, the SA node, is constantly firing off electrical signals. Those autonomic motor neurons can increase the rate of firing or slow down the rate of firing. But the SA node is the pacemaker of the heart, and the autonomic motor neurons are simply acting to adjust or modulate it. So that's how our nervous system, our brain, and since these are autonomic motor neurons, they work automatically without us thinking about it. But nevertheless, our brain can speed up that rate of activity or slow it down. On page N11, so the next question is blood supply to the myocardium in the middle of page N11. Blood supply to the heart muscle. The middle layer of the wall of the heart is called the myocardium. You'll recall there's an inner endocardium and an outer epicardium. We've talked about that already. The thickest layer is the heart muscle itself, the myocardium. Now, you might have thought that since there's blood inside the heart, it wouldn't need any blood supply. But every part of our body needs little capillaries to provide oxygen and nutrients to it. Even the walls of our blood vessels, as we'll see, need their own capillaries to supply oxygenated blood to the walls of the vessels. So the first arteries that branch off the huge aorta are the right and left coronary arteries. They encircle the heart, as we've learned, along the atrioventricular or coronary sulcus, as we've learned previously. We can see this really nicely on page, well, let's look on N13 first, on N13. And on the top of N13, on your top left, so this is a front view of the heart. This is the huge aorta. The aorta. Now we know that the left ventricle ejects oxygenated blood out into the aorta. And if you don't know that, I know you will know that for the test because you're memorizing how blood flows. That's why I'm forcing you to do this. Now, we know that there's about 100 smaller arteries that branch off that huge aorta to carry oxygenated blood up to our head, to our arms, to our legs, to our digestive tract, everywhere in our body. And in fact, the very first arteries that branch off that aorta are the right and left coronary arteries branching off right here. You know, the picture that would also help us that we've used before to point this out is on page 05. On page 05, you'll remember this scary drawing. None of it specifically you have to know. Shows this huge aorta, the biggest blood vessel in the body. This is page 05. And it shows those about 100 other arteries branching off it. And look right here, branching off at the very beginning are the right and left coronary arteries. They branch off the ascending aorta. So we had talked about that previously.
Is that visible on the CAT?
You can see the coronary arteries on the surface of the heart. All right, so these coronary arteries, of course, have many subdivisions. They subdivide into smaller and smaller branches to nourish the heart muscle. And we wrote right here in the outline that these coronary arteries form many anastomoses with each other. Now, we've learned that word, anastomosis. It was on the top of page N2 when we said that a capillary bed is an anastomotic network of capillaries, meaning an interconnecting network. So there's a whole bunch of interconnections between these coronary vessels. This is also known as collateral circulation. And yes, I want you to know that. I underlined it, collateral circulation. Now, it happens to be that the more collateral circulation, the more anastomoses, the more interconnections you have between these coronary branches of the coronary vessels, the better off you are. You'd say, why? Because you can provide lots of oxygenated blood everywhere. And you'd say, well, that's wonderful that it's having a lot of collateral circulation or interconnections is good, but what can I do about that? And the answer is aerobic exercise. Aerobic exercise, cardio exercise, endurance exercise, we have learned, refers to exercise that involves speeding up your heart rate and making your heart work harder. Does lifting weights with your arms, is that a cardio workout? That is not a cardio workout. How about running on a treadmill? That's a cardio workout. That speeds up your heart rate. Lifting weights with your arms does not. So when you make your heart work harder, just like making your arms work harder, if you make your arm muscles work harder, your arm muscles become bigger and stronger and more vascularized. They develop more blood vessels to nourish them. And that's why you'll see these bodybuilders with bulging blood vessels in their muscles as well. Similarly, when you make your heart work harder, the heart gets bigger and stronger and becomes more vascularized. So that's how you increase collateral circulation. Why these additional blood vessels are good is that if you ever suffer a blockage of a little coronary vessel or a branch of it, if there's enough interconnections, the blood can still navigate around that blocked area and still provide adequate oxygenated blood to all parts of your heart muscle. So the more interconnections you've got, the better off you are. Now, there are many branches off the right and left coronary artery. Now, I've listed 2 branches off each. In fact, I'm only going to ask you to know 1 branch off each one of them. I wrote branching off the right coronary artery is a marginal branch that supplies the SA node. I'm going to show you where it is, but I'm not going to test you on it. But I am going to show you and to ask you to know the posterior descending branch of the right coronary artery. We can see this right here in the picture. This is the right coronary artery. Here it is. And you'll notice here's this little branch coming off it called the right marginal branch. I'm not going to test you on it. I just want to explain that that little branch is what supplies the heart muscle cells of the SA node, the pacemaker of the heart. Now just imagine if there was a blockage, an obstruction for some reason, a blood clot that stopped oxygenated blood from flowing to that SA node, then the SA node would get sick and even die. It would stop working. That would affect the normal pacemaker of your heart. So obviously knowing which little branches supply which parts of your heart is relevant in terms of understanding how your heart muscle works. I'm not going to test you on that, I'm just explaining it. What I do want you to know is that this right coronary artery kind of swings around to the back side of the heart. This is on the back side. And there's a major branch off the right coronary artery running downwards on the back side of the heart called the posterior descending branch of the right coronary artery. Its name is very descriptive. It's on the posterior backside going downwards. That is the major artery running downwards along the backside of your heart. All right, and it's a branch off the right coronary artery. Now, in our outline, we next wrote, under left coronary artery, I gave you 2 branches. Again, I'm only going to ask you to know one. There's a circumflex branch. Not going to ask you to know it. And then I put a star, the anterior interventricular, or also known as anterior descending branch of the left coronary artery. Again, we can see this right here in this picture. Here's the left coronary artery, and it has this branch carrying blood downwards right on the front surface of the heart, called the anterior, which means front, descending branch. That is the major artery running along the front side, the front surface or anterior surface of the heart, supplying oxygenated blood on the front side of the heart. So it's just the idea of knowing a little bit about all these various branches, which when people do have, when they have problems called angina pectoris and myocardial infarctions and other things that we're going to tell you more about shortly, that involves blood flow through these various branches of the coronary arteries. Now, as the oxygenated blood nourishes the myocardium through capillaries, little blood vessels, the capillaries join together to form small veins. And if we look on the previous page, N12, on the top picture of N12, this happens to be a posterior view of the heart. This is the top picture is the back side of the heart. So we know that when we're looking at the back side of a patient, their right corresponds with our right. So this is the right side of the heart, right atrium, right ventricle. This is the left atrium, left ventricle. And right here, it shows these smaller cardiac veins. One's shown right here. And these cardiac veins are carrying blood from the heart muscle, and they flow into this big vein on the back side of the heart called the coronary sinus, or coronary sinus vein. We had mentioned that before. And we had said some veins in our body have a very thin wall, and they're called sinuses or venous sinuses. And this blood, low in oxygen, flows right into the right atrium. And we had learned that, in fact, the right atrium actually receives blood from 3 veins, low in oxygen. The superior vena cava, bringing blood low in oxygen from the head and arms, upper part of the body, to the right atrium. Inferior vena cava, bringing blood low in oxygen from the lower part of the body. You can certainly see these on the CAT. And the coronary sinus, bringing blood low in oxygen from the heart muscle itself. And so we had summarized all this in various flow charts. I'll remind you on page 017, which we covered last time. We summarized exactly this on page 017, how these 3 veins bring blood to the right atrium. So we have talked about all of that previously. Okay, and on the bottom of N13, so on the bottom of N13, so the coronary sinus is located in that atrioventricular sulcus or coronary sulcus on the posterior or back side of the heart. It receives blood from cardiac veins and it empties. It flows into the right atrium, right near the inferior vena cava. All right, so that's what we've just been describing is how blood, the blood supply to the heart muscle itself. On page N14, so I want to speak briefly about pathologies and disorders of the heart. I try to tell you a little bit about pathologies and disorders of each part of the body, just because I think, number one, we're interested in the health field, so we're interested in what could go wrong. And also, sometimes by understanding the diseases and disorders, it illuminates, it helps us better understand why learning anatomy or physiology are important. So the first thing is rheumatic heart disease. Now, rheumatic heart disease is an autoimmune disease. We've talked about autoimmune diseases before. This is where your own immune system, your white blood cells and antibodies, attack your own body. Now, obviously, that should not happen. but it does happen in some people, presumably for genetic reasons, because of genetic predispositions to this. We have spoken previously about rheumatoid arthritis, where the immune system attacks the synovial joints. That's one of the causes of arthritis. There are other types of arthritis. Now, in this case, rheumatic heart disease, the immune system attacks the endocardial lining of the heart, the inner lining, causing endocarditis. It also attacks the valves of the heart, which are covered by endocardium. So it attacks the valves, destroys the valves. Now, something about autoimmune diseases that I have not told you previously is the following. You know, if somebody is going to have an autoimmune disease, they weren't born with it. They didn't have it as an infant. It usually starts, the symptoms of the autoimmune disease usually appear during childhood or during the teen years, or by the latest, by the 20s. So the question is, if they've got this genetic predisposition, why did that newborn baby show the symptoms of the autoimmune disease? Why did it only appear in the later in childhood or as a teenager or whatever? And the answer is because it has to be brought on or triggered by an infection. It appears that these people who have genetic predispositions to an autoimmune disease, they have an infection, and when their immune system starts to attack the infectious agent, when your immune system starts to attack the bacterial infection or viral infection, it can't tell the difference between the infectious agent and part of their own body. So it starts to attack not only the bad guy, which is fine, but also part of their own body. So we're starting to learn which autoimmune diseases are initiated or brought on, triggered by which infectious agents. So it happens to be the rheumatic heart disease is triggered by a strep throat. Now, probably many of us have had a strep throat, right? It's just that we don't have an autoimmune disease. So when we get a strep throat, our immune system attacks the Streptococcus bacteria, causing our throat to be all red and sore. And okay, we get an antibiotic and we're fine. But in those people who have a genetic predisposition to rheumatic heart disease, when they get their first strep throat during childhood, or whenever that happens, that's when their immune system, as it starts to attack the bacteria, which is fine, at the same time starts to attack the endocardium and valves of their heart for the first time.
But it has no relation to the throat and
No, it's just that the immune system can't tell the difference. They are antigenically, they basically just can't tell the difference between the bad guy and that part of their body for some reason. So you'll hear more about this in not only physiology but microbiology when you cover immunology, or at least one should. So that's what brings on this. Now, why rheumatic heart disease is especially important in the fields of dentistry and dental hygiene is because there are a lot of streptococci bacteria that are endemic, naturally live in the mouth. And anytime a dentist or dental hygienist is doing any kind of procedure, especially if there's bleeding, and there almost always is, it's always possible for the bacteria, the Streptococcus bacteria, to enter the body and trigger an infection. Now, if any of us get an infection from a dental procedure, all right, so then they prescribe you some penicillin V, they give you some antibiotic, and it's fine. But if somebody has a genetic predisposition to rheumatic heart disease, if they get a strep infection, that again triggers their immune system to again attack the valves of their heart, which is really very, very dangerous. So up until about 3-4 years ago, it was the American Heart Association had a required protocol that anytime any dental procedure, including scaling of teeth by dental hygienists, was performed in somebody with a history of rheumatic heart disease, you had to pre-medicate them with an antibiotic before you could actually do the procedure. That was even written into the California State Code, which means that if a dentist failed to pre-medicate the patient with an antibiotic, they could have grounds for suing. The patient could sue the dentist because they had put them at increased risk of having another attack on the valves of their heart. Now, the American Heart Association changed their protocol about 3-4 years ago. They no longer require pre-medication with an antibiotic. I assume the California state code, the laws have changed, but I know that many dentists will still pre-medicate a patient because that's how they were trained to do that. You still have to handle somebody with a history of rheumatic heart disease much more carefully than your regular patient because of this problem with possibly triggering another episode of the immune system attacking the valves of the heart. So it's interesting because of the interconnections of the body that here we are talking about the heart. We mentioned an autoimmune disease, and we mentioned that it's important not only in medicine, but it's also very important in the world of dentistry. So you never know how these things are interconnected. Now, what is coronary artery disease? Coronary artery disease, abbreviated CAD, sometimes it's also called coronary heart disease, or CHD, means the same thing. This is associated with atherosclerotic plaque accumulating on the inner walls of the coronary arteries. Let's look on page N14B. So on N14B, I created a picture of a cutaway view of a blood vessel, an artery. And we show that this artery has a bunch of crud that's built up on the inner walls. And that stuff is mostly fat and cholesterol and calcium. This is known as atherosclerotic plaque. Atherosclerotic plaque. Of course, when dentists hear the term plaque, they're thinking of something on the surface of the teeth, but this is atherosclerotic plaque. Athero means fat. Now, this buildup of fat on the inner walls of our arteries occurs in all the arteries of our body, not just the coronary arteries. But, you know, the coronary arteries that supply oxygenated blood to our heart, that's more important than worrying about clogging up of our arteries to our gallbladder or to our left earlobe. So there's certain parts of organs of our body where if they start to get clogged up arteries, this is going to have much more serious ramifications than clogging up and reduced blood flow to your left earlobe. Now, obviously, the more crud that clogs up the artery, and this is known if it occurs in a coronary artery as coronary artery disease, what is that doing to the amount of blood, oxygenated blood flowing through this vessel? It's reducing it because the vessel is becoming stenotic, occluded. So going back, we'll come back to this page in a moment, but going back to N14. So on N14, under coronary artery disease, we wrote it can result in what's called angina pectoris. So we wrote that coronary artery disease, which is this atherosclerotic plaque building up on the inside wall of a coronary artery, causes stenosis of the lumen. Have we learned the word stenosis? It means narrowing, constriction. We first used that word in pyloric stenosis, narrowing or constriction of the pylorus area of the stomach. So it's used in all different contexts. It just means a narrowing, and that reduces the flow of oxygenated blood to some part of the heart muscle. Some part of the heart muscle is getting less oxygenated blood than normal. When a tissue isn't getting enough oxygen, the word that we use is ischemia. Ischemia means not enough oxygen. We can use that term for any tissue of the body. Renal ischemia, hepatic ischemia, cerebroischemia. This is myocardial ischemia, heart muscle ischemia. Now, when the heart muscle isn't getting enough oxygen, it creates a pain. Interestingly, the pain does not feel like it's coming from the heart. It actually feels like it's coming from the left chest, radiating down the medial side of the left arm. This referred pain, this pain that's felt in the left shoulder, along the medial side of the left arm, is called angina pectoris, pectoral, the shoulder area, the chest area. So that refers to this pain that's created. Now, what happens is the more clogged up these arteries become, the more frequently the person starts to experience this angina pectoris. This is every time they're experiencing it, it means that their heart muscle isn't getting enough oxygen, which is serious. So they have to do something about it. Eventually, what they might end up having to do is where the coronary arteries are most occluded or blocked, they may have to take arteries from somewhere else in your body where you don't need them as much and remove them and create bypasses around the most clogged up sections. This is known as a coronary bypass. The word we're saying is bypass. Because these arteries are allowing the bypassing of the most clogged up sections to increase blood flow. This would be known as a triple bypass. You can have a single, a double, a triple, a quadruple bypass, whatever it takes to increase oxygenated blood flow to the clogged up areas. Now, as bad as this is, this problem of coronary artery disease, clogging up of the coronary arteries, it gets even worse. Because this coronary artery disease can increase the risk of what's called a coronary thrombosis. Now, a thrombosis means a blood clot, because it increases the risk of a blood clot forming in the artery. And if the blood clot forms, and I'm going to show you a picture of this in a moment, then that stops the flow of all blood through that artery. So now you don't have reduced flow, you have zero flow of oxygenated blood. And when you have zero flow, no flow, stopping the flow of all blood through that vessel, the heart muscle isn't just ischemic, not getting enough oxygen. The heart muscle dies. And the term we use for death is infarction. Again, that term, just like ischemia, can be applied to any tissue or organ of the body. You can have renal infarction, hepatic infarction, cerebral infarction, just means death. But the context that, if you've ever heard the word before, the most common is myocardial infarction, death of the heart muscle. Now, you know this myocardial infarction, or MI, as it's abbreviated better by the expression heart attack. That's what a heart attack is. It's where the heart muscle dies because of a coronary thrombosis, a blood clot. Now, I want to show you how this happens. If we again return, but this time to N14A, the very next page, N14A. So on N14A, all right, so I want to just tell you a little bit about blood clotting. Now, you're going to hear a lot more about blood clotting, a very important subject, in physiology. We'll just give you an introduction to it. Now, this shows a blood vessel, and it's been cut. You can see it's been cut. Now, what's really cool about our body is that we know that we can cut ourselves, so we've got a built-in mechanism to prevent us from bleeding to death. Circulating in our bloodstream all the time are these little guys called blood platelets. They're known as blood platelets or thrombocytes. What are they? They're actually pieces of cells. They're little fragments of cells that originate in our bone marrow. So not only are red blood cells and white blood cells produced in our bone marrow, so are blood platelets or thrombocytes. They are made in our bone marrow. And they circulate in our bloodstream. Now, they are designed to attach or aggregate to rough edges. So when you cut a blood vessel, now you've got this rough edge. So these little blood platelets that are always moving through the bloodstream, they just start to attach or aggregate. Aggregate means to attach. They usually use the word aggregate. So they attach to the rough edges, and initially they form a little, what's called a platelet plug. So here you can see in the middle picture, there's like a whole group of blood platelets that are kind of plugging up this cut, their hole in the wall of vessel. But more importantly, they release a chemical. They release a chemical called PF. PF stands for platelet factor, or PF. Now, this chemical initiates a complex series of biochemical reactions that you will learn about in physiology. It's a whole series of physiological or biochemical reactions. It culminates or ultimately ends up in the formation of a fibrin clot. Now, what is a fibrin clot? A fibrin clot is called that because, and it's written right here as well, it's made up of a protein called fibrin. So this chemical initiates a complex series of chemical reactions that forms this protein to collect right here. It looks like a spider web. And incidentally, just as this is made up of a fibrin protein, and it looks like a spider web, a real spider web is made up of protein. So it very much looks like a spider web. Now the whole purpose of this is to stop the blood from flowing so that it doesn't flow out that cut wall of the vessel. So that's the whole idea, so you don't bleed to death. So that's fine. It stops for a while until this wall of this blood vessel can be repaired. And we know it'll be repaired by cell division or mitosis, and we'll reform that wall, and then the blood clot can be dissolved, and blood will then reflow through that vessel after it's been repaired. In fact, here we indicated that as the wall has been repaired, right here, so there's actually a chemical called plasmin. I'm not asking you to know this. You'll learn it in physiology. There's a chemical called plasmin that actually dissolves that clot, and once it dissolves, then blood starts to flow through the vessel again. Okay, fine. Now you've learned a little bit about what happens when you cut a vessel and you get a blood clot so that you don't bleed to death. What's this got to do with coronary thrombosis? On the next page, N14b, so in fact you'll notice the title of this is Blood Clotting in Response to Atherosclerotic Plaque. Look, here we have this artery, let's say it's a coronary artery, and it's got all this atherosclerotic plaque. That creates a rough surface. And we said that circulating in our bloodstream all the time are these little platelets. And we said they are designed to attach to rough surfaces. Normally the rough surface would be created by a cut wall of a vessel. But now we've got rough surfaces due to all that crud that's built up on the inner walls. So these platelets start to aggregate or attach, and as we see in the middle picture, they start to release that chemical called platelet factor, which causes the forming of a fibrin clot. Now we've stopped the flow of blood through this vessel. It's not because the vessel was cut. It's because of this atherosclerotic plaque. It caused the platelets to now incorrectly release this chemical, and now we've stopped the flow of all blood through this vessel. So the result of this now is whatever part of the heart muscle that's supposed to get oxygenated blood through this vessel isn't getting any, not reduced, it's getting zero oxygenated blood. So heart muscle can live, now you may have learned brain cells can live 4 minutes without oxygen, 4 minutes. Heart muscle cells can live somewhere between 12 to 15 minutes without oxygen. But if after 12 to 15 minutes of the blood, oxygenated blood not flowing through this vessel, this branch of a coronary vessel, that heart muscle dies. And that's called a myocardial infarction, an MI, or what we commonly call, by lay people, a heart attack. Now, whether the person survives that heart attack or not depends upon how much of their heart muscle died. And it could have been a massive heart attack where a major part of the heart muscle died. It could be a very small part. It also depends upon exactly where, which part of the heart. Was it the pacemaker of the heart? Was it some other part of the heart? Because that may be more important than some other part dying. Incidentally, I'm not going to get into this, but we've mentioned that there's this chemical called plasmin that dissolves clots. So the current approach that's used when somebody has a coronary thrombosis, a blood clot in a coronary artery, is they actually activate this plasmin to dissolve that clot. And if they can do that within the 12 to 15 minute window before the heart muscle has died, they can save that person from any permanent heart muscle death. Anyhow, back on page N14, so let's just summarize what we said about coronary thrombosis. So the coronary artery disease, the atherosclerotic plaque, increases the risk of a coronary thrombosis, a blood clot. That stops all the blood from flowing through that vessel, leading to heart muscle death or myocardial infarction. Now, it's very important whether we're looking at this sequence that we wrote out for what leads to angina pectoris, or this sequence leading to what results in a myocardial infarction, that you understand the proper sequence. It's not enough to just say, well, I learned all the words. You need to know the order in which these things happen. It's a story. I just told you a story of what happens, and then what happens next, and what happens after that. You need to know the order of the story. Okay, now, on the bottom of N14, what are conduction blocks? A conduction block is when you get myocardial ischemia or myocardial infarction in the electrical conducting system. So on the previous page, hadn't we said that there's a little branch off the coronary artery? I said you don't have to know, it's called the marginal branch, that supplies oxygenated blood to the SA node, the pacemaker of the heart. What if you get you get reduced blood flow or no blood flow through the marginal branch? Then you're going to have myocardial ischemia or myocardial infarction of the SA node. The SA node is part of the electrical conducting system. So that means the electrical conducting system, it now has a conduction block. It's not conducting normally. So what do we call these? These are called conduction blocks. The conduction of the electrical current isn't normal. So it could be a conduction block at the pacemaker, at the SA node, at the AV node, a bundle branch block. So any ischemia or infarction involving the electrical conduction system is known as a conduction block. It's blocking the conduction of an electrical signal, an electrical current, the action potential. Now, if the electrical current doesn't flow through the heart properly, then the heart doesn't contract properly, because it is this proper spread of the electrical current that leads to the proper contraction of the heart muscle. Remember, what causes a muscle to contract is the electrical current or action potential. So if the electrical current isn't flowing through the heart normally, then it doesn't contract normally. So that results in what's called an abnormal rhythm, an arrhythmia of the heart, where the heart doesn't beat or contract in the normal way because it's not, the electrical current is not moving in the normal way. So you can see how all these things are interconnected. On page N15, on N15 at the top, what is a heart murmur? So N15, very next page. And a heart murmur is an abnormal sound. So when you're listening to somebody's heart, and especially the valves of the heart, and in physiology you'll learn about normal heart sounds and all that, if you're hearing an abnormal sound, that's called a murmur, and what's creating it is a problem with the valve. Now, why wouldn't the valve be working? Well, we mentioned already earlier on M14 at the top, rheumatic heart disease. In this autoimmune disease, the immune system incorrectly attacks the valves of their heart, destroying them. It could also be congenital. That literally means with birth. Sometimes people are simply born with valves that didn't form properly. You could be formed with any part of the body that didn't develop properly. Now, what do you do if the valves don't work? Either because you were born that way or because of rheumatic heart disease or some other problem. So then they have to do open heart surgery and put in a prosthetic valve. You'd say, a what? So this is shown at the bottom of the page. And you'd say, what is that word you just said? It's written right here, prosthetic heart valve. The word prosthetic means artificial. Prosthetic means artificial. If somebody had a prosthetic leg, right? We see soldiers who've lost their legs, so they have a prosthetic leg. All right? So this is a prosthetic heart valve. It kind of looks like this. Looks like a little marble in a cage. So they literally do open up their heart. They will cut out the defective valve, and they will replace it with one of these artificial or prosthetic valves. In this X-ray that you see right here, this is a lateral view of the chest where the you're looking at them from this side, and you can see on the X-ray it shows two prosthetic valves, and as it indicates right here, they have a prosthetic aortic and mitral valve. And we know that the doctors like to call the left AV valve or bicuspid valve the mitral valve. You have to know all three terms. So the person's got two valves that have been replaced. Now remember, there are four valves in the heart, a right AV valve or a tricuspid and a pulmonary valve, and we have a left AV valve, also known as a bicuspid or mitral, and an aortic valve. So any one or all four of the valves might need to be replaced.